you have that was printed has had some modifications, and just to take care of some of this, the time that we recovered and those that we spent, so that everybody is accommodated in the program. So for this morning, the morning session, we're going to have expert talks, and this will be facilitated by Lydia Juki and Jay Mukaya. So the expert talks will be around multi-sectoral synergies in successful integration of GBV services by Dr. Omar. And then we'll have integrating HIV OVC services within the UHC framework by Kamati. And then we'll have integrating systems for seamless service provision. The expanded Kenya EMR case, this is going to be done by Bernard. And then we have the role of NSDCC in the integration of processes by Enchep Coin. Yeah, so after that, this should go up to 10:30, and in between we'll also have awards to counties. We'll have awards to counties, where we'll have awards presented to the counties. Then by 10:30 we should break for tea, and then we'll break into the breakout rooms, which I'll share later on, where individuals are supposed to go. But still the halls remain. We'll have here the main tent, the Olive Hall, which is the place where we have the opening dinner. We have track 3 on the 3rd floor boardroom, and then the track 4 in 3rd floor at the rooftop, and then track 5 at Zion Hall in the 1st floor. Yeah, so the tracks should run up to should run up to 12:30. Then at 12:40 should convene here for a closing session. So we anticipate by 13:40 we should break for lunch and proceed now. After lunch, everybody will be just free to travel to their different places. Otherwise, thank you and karibuni sana.
Thank you so much, Exosi. Let's give him appreciation. Thank you, and welcome all. As I've told you that the day will be a little bit short. We don't expect long, so we have to have that right knowledge since the first day we came here, and I believe everyone has now the right knowledge. We've given Christ on the earth by our pastor, and I believe we will be sorted. Money in the pocket. Make sure you've signed, make sure you do the necessary, so at least you'll be sorted. Food on the table. I believe everyone on my partner the whole week. And the balance of the money you'll take also food home. Good relationship with your neighbor. Everyone greet the neighbor. So salimie jiran. Yes, that is good relationship with the neighbor, extending to the counties and to your families. And then also relationship with God. Relationship with God. Are we related with God? Yes. And good relationship with the environment. Tupande miti. Thank you so much. I'll not take so much. I want to welcome Lydia, so at least they take the next session. As he comes, they will take with Dr. Mokoya. So welcome, Lydia. Clap for her as she comes, so at least we start. Yes, we can. Yes, we can. Or we don't. Yes, welcome, Lydia. Karibu sana. Thank you.
Thank you very much. Good morning. Good morning once again. I'm very happy to see bright faces. This program belongs to who? Yes? It belongs to us, isn't it? We need to agree that we are coming back next time because this program belongs to us, isn't it? There are those people who have not said anything since we came in. So I want us to own this program. How are we going to own it? They're going to tell us that it belongs to us. That's how it belongs to us. Eh? But this group is going to Give us that bit here. 2, 2, 2, 2. Eben, 2, 2, 2, 2. They are going to say, it belongs to, see, that is what we've agreed. And then this other group is going to ask, to whom to, is going to give us that bit of to whom to. Ebu semeni? To whom to whom to whom to. And then? Okay. Let me start again. This one is going to say to. And then? To whom does it belong to? And then who? You? It belongs to us. So let's do it all of us. To whom to? We want to start all of us. To whom to? To? No. I have confused you. You're going to say to. And then you say, to whom does it belong to? And then you say, it belongs to? Tuanze sote pamoja. Good. Let's do it once more. Yes, thank you very much. That's a note we have taken. When we get back to our facilities, to our stations, we are going to support each other. We implement or we try to prove that whatever happened is that can also happen on the ground, isn't it? So I want to take this opportunity to welcome our first presenter. The day is quite short, and we have the first presenter, Dr. Omar. It's not there. Integrating HIV OVC services within the UHC framework. Yes, let's put our hands together for Madam as she comes. It's a very short day, so I believe we have a plan to write those good practices that we are going to put. Karibu sana, Madam. Thank you.
Hi, everyone. Good morning. I believe we had a good night and we have a good, bright morning this day. So I'm going to take you through integrating HIV OVC services within the Universal Health Coverage Framework. And my name is Rtwg. I work for USAID for Better Health, a program of St. John's Community Center. We are covering, as USAID for Better Health, 6 counties, that is Kajiado, Kitui, Machakos, Makueni, Murang'a, and Nakuru. And our main goal, which we are going to see how it's aligned to universal health coverage, is to increase access to quality health and social services for orphans and vulnerable children and their families. And we do that within 3 objectives. Now, one of them is to have increased targeted services for HIV exposed, infected, and affected children, that is orphans and vulnerable children. Also to increase economic stability of households to care and protect OVC. And also to strengthen capacity of local systems and structures to support OVC services. How do we integrate OVC services within universal health coverage framework? One of them, I decided to look at what is the goal of universal health coverage. It is to ensure that all Kenyans have access to essential quality health services without suffering financial hardships. I also compared this with the goal of USAID for Better Health, which is targeting orphans and vulnerable children. And I realized our goals are almost the same. Because the goal for USAID for Better Health is to increase access to quality health and social services for orphans and vulnerable children and their families. So take note of access, both have access. Quality services, it's appearing in both OVC services and also in UHC framework. And I'm going to address that through 4 approaches or 4 areas. One of them is approach. We target orphans and vulnerable children and their households through 2 approaches, that is comprehensive, which is through case management, and preventive approach. The other one, I will look at quality of services provided. Are they timely, accessible? And how are we doing that? Through support or financially, need-based, and that they recognizes also the rights of beneficiaries. Service providers, we have community-based mechanisms that utilizes the lowest level of health service providers. Those are the community health promoters. And in OVC programming, we call them case managers, or no, not managers, case workers, but some of them now have as CHPs. Next slide. Implementation approach of comprehensive. We target orphans and vulnerable children and their families. And it is a model which is family-centered and child-focused. It is targeting HIV-exposed orphans and also affected and infected. And they are below age 18. So when I'm discussing orphans and vulnerable children, take note it's below age 18. And 18 to 20 years if they are in school or they are undertaking an appropriate economic strengthening intervention. The other one is preventive, which targets age 10 to 14 years. And these children, they are targeted through evidence-based interventions. We also target the parents of the same through the same evidence-based interventions. Various OVC programs have different EBIs, but for USAID for Better Health, which I'm giving as an example in this presentation, we are having healthy choices for better health, for better future, targeting children, and Family Matters Program 1, targeting caregivers of the same age category. Case management approach has 7 steps. As I mentioned, the approach of preventive comprehensive is through case management. And the first step is identification of these vulnerable children and their families. Then in step 2, we ensure that they are enrolled and in the program, and this will be elaborated further in the other presentations, which will be done within the sessions or breakaways by some specialized people who have taken this as one of their area of research. And as number 3 is assessing vulnerable children and their families. And after assessing them, you develop an individual case plan for every child within that household and even for the entire household. From there, we implement case plan, and this is done through offering services directly as a program, and also through linkages and referrals. That's how stakeholders and other people who are implementing other services come in. Then from there is monitoring of case plan, implementation, and if the program, or if that household has really pleased the program and has met all the set benchmarks, and the benchmarks are set or aligned to 4 domains of health, stable, safe, and schools. That is education, ensuring that the household is stable economically, ensuring that the issue of protection of the child is taken care of, and health. If the 9 benchmarks are met within those 4 parameters, then we say this child and the entire household, if all the children in that household are able to meet those 9 benchmarks, then we say it is ready to graduate. So the red box shows that they can graduate. If not, then we can start the cycle again. Quality services and the providers, I want just to highlight who are the people who provide these quality services and how. There is use of orphans and OVC program approved tools, which are centralized system and they are timely. And data is analyzed for service provision. As I have mentioned, it's case plans, which inform the service provision. Case management approach is done at household level. That one I've already mentioned that. And as I mentioned, there are tools. There is a tool which helps us to assess the readiness of that household. That is case plan achievement readiness assessment. Each beneficiary is attached to a community resource person, the CHPs or case workers where we don't have CHPs, and the monitoring is done on weekly, monthly, and quarterly basis, as per the case plan, of course. In Nakuru County, the county which has made us to be here of the 6 counties we have mentioned, 51% of the community volunteers, the case workers, they are also doubling as our CHPs in the government program. So you can see how the two are really working together. Then community quality of services are monitored by quality improvement teams. These are at community level. Yesterday we heard about the clinical ones at the facility level. This one at community level services. This is just a photo of how we are monitoring those services at the household level. You can see a child on doing its homework being monitored by a case worker or a CHP at home. Areas of integration, one of them is prevention. As you know, the 395, so I'll just highlight on each how we do, and it's not as comprehensive. You can read more details when you just search on OVC programming versus the UST. So use of case workers. In this case, we use case workers at community level to monitor the under 5s to ensure that they get the necessary immunizations. We also monitor HIV services in the community and also household. There is also structured referral networks which facilitate healthy services and other services also to reach the households in the community. Number 2, we also build the capacity of case workers as community resource persons in HIV management to support screening, referral for HIV testing, facilitating disclosure plus HIV and GBV prevention through EBIs. I know a lot has been spoken throughout the week along these areas, but it was not narrowed to OBC. So you can see those are services we do at the community level. We also engage case workers in facilitating nutrition, trainings, and monitoring. Case workers also doubling as mentor mothers, support elimination of mother-to-child transmission. We also have support of HIV positive pregnant mothers and adolescents who are at risk of transmitting HIV. The other area is treatment. We are integrating also on the area of treatment by having CHPs monitor community at household, CHPs monitor ART at community level and to the household. And one of them is sensitizing caregivers and OBC on ART use. They also support in pill count, video and audio direct observed therapy, that is DOT. It may not be done in all the counties, but in some of our 6 counties, it is happening. Conducting work and referring those who need who have a need to the relevant support. Also participating in multidisciplinary teams, which most of you belong to. And here we are able to address socioeconomic factors which contribute to the failure of adhering to treatment. And this one is done through multidisciplinary team, and also we facilitate the support of children to the clinic to pick their medication. That is the last 95, where we are looking at viral suppression. Here we monitor ART adherence at the community and the household level. We support disclosure at household level. You know, disclosure, it is age appropriate, and we do that. We work with the children and also their caregivers, support participation of Girl HIV in UTZ clubs and also support groups. We also join households visit together with the other teams who are in disciplinary teams. That is the other IPs who are implementing clinical, and also the government team who are working in our facilities. We also do dissemination of U2U messages towards achieving suppression. We also empower households economically for stability. You know, when a household is stable, we will not experience, like one presenter did yesterday, the issue of lack of food, and which can affect the households. Then the other component of the 4 I mentioned, the last one is on data collection and analysis and use. Implementation, research and technology is key in OVC programming, more so for USAID for Better Health. And through case management, the CHPs collect data which is centrally analyzed to facilitate quality service provision through child protection information system. This is a system for capturing children data, a government one, just like DHIS2 and others for the health people. It also implementation technology research also helps in digitizing digitization of case management. This is something we are on process and we are doing very well through the help of the health IT with the partner charged with that in the USAID circles. And we are able to digitize our case management approaches. And we are doing very well, as you will see later, working with the county government for approval to install CPMIS in CHP's GOK provided smartphones. We are not renovating the wheel, we are not buying new gadgets. We are working with our government to do that. And like County of Nakuru, we have already received some approvals. We have had preliminary meetings. We have received approvals and we are together with the county planning how to start pilot in 2 sub-counties. We are also conducting surveys using COBO, and we are able to have our CHPs taught how to use these gadgets. So far, we have done some of the assessments using this COBO Collect, and it has really informed program on how to move around with our implementation. And one of them is assessment of knowledge of CHPs on case management. This is assessment we did a few months ago, and it was very informative. I thought we could be able to present it in this forum, but I believe in the next one we'll be able to present some of the findings. The other one is knowledge of OVC, how they are valuing the services we are offering to them. The other one is collaborating, learning, and adapting, that is CLA. We have applied this to integrate the lessons learned during the implementation and also to help them inform us on the services we are offering to children. That's how you can see data is coming in when it comes to the issue of service provision. And this has helped us in conducting surveys in different program themes to improve service provision. And we have done quite a number of surveys as program. Some of our people who lead us in this, they will be presenting this afternoon. And some of these things, if you happen to learn in their sessions, you'll be able to learn more about them. Also, we have focused group discussions to get feedback from the beneficiaries on quality of services. Those are the OVC and their caregivers. In conclusion, I just want to highlight that UHC, and if we embrace it, that is universal health coverage, if we embrace it, we'll be able to be serving orphans and vulnerable children well across all HIV services. Whether you are a partner implementing OVC services, or you are a clinician who is in the facility, or you are a partner who is implementing a program taking care of the pediatric ARTs and all that, you should be the right person to know that you're embracing UHC principles of quality, people-centeredness, efficiency, social solidarity, and multi-sectoral approach. You will be doing well to the OVC program, because that is how we are looking at our sustainability. Also, the other area is enhancing the capacity of community workforce, like case workers, CHPs, mentor mothers. We will be in a position to prevent health and also health-related issues, which we have really been talking about in this conference, that prevention is not being taken care of. But if we do that, we'll be doing it for the OVC or for the children. We'll be promoting early identification, and hence there will be timely referral and service provision for OBC. Also timely data collection through improved digitization process, which we are doing as a program. It is helping us to integrate more of OBC indicators to government indicators, and this one will be able to help us lead in decision making and also have improved services, both as partners and also as governments who are the owners of the programs which we are supporting as partners to implement. The last one is advocacy for counties to allocate resources to HIV, OBC support, social services. I want to mention that counties can do this. I'm happy the first day we had some politicians who are very passionate on what is happening and also the budgets for supporting the health component. And I want to request that even as we work with the counties, let's advocate for more. Let's ask the lawmakers to advocate for more allocation of resources to the orphans and vulnerable children. As much as they will do for the health, let them do also for orphans and vulnerable children, because this is the only way we will have our children who are HIV positive live their full life and enjoy every bit of their life. In Nakuru County, we have had very good working relationship with the county government, just as it has also been in our other 5 counties. And in Nakuru County, we have been assigned one of the staff to fully support the county and also the Department of Health in OBC services. That is a great work done by the county of Nakuru. And we feel if every county we are in, the 6 counties who are represented here, they work closely with the partners and they own the program, and they know these projects are coming and going, but the program belongs to us, the children belong to us. Then we will be able to integrate HIV OBC services properly within UHC framework. That is it from me. God bless you.
Thank you very much, Madam. And we should sit on the side. We'll take the questions at the end. So let's appreciate her. Naomba tusimame tafadhali. It's very unhealthy to sit for more than 30 minutes. Tusimame tumpe Karabada. 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 Senorita. Oh, thank you. You can see the men smiling. Thank you very much. So Dr. Mugai will take us through the next moderation. He's going to hold the presenters, and thank you very much.
Good morning. Good morning. Thank you very much, Ikamachi, for that very clear presentation. We are quickly moving on, and the next presenter, Nixon, just point. Okay, so a little change here upon consultation. We will now invite the County Commissioner, Dr. Ahmed Omar, for his presentation. And wouldn't you appreciate Dr. Omar, apart from his very engaging administrative responsibilities, he still is able to put together a presentation. Once more, let's clap for Dr. Omar. Thank you, Dr. Omar.
Thank you very much. Ladies and gentlemen, good morning. Good morning. Good morning, ladies and gentlemen.
Good morning.
Okay. The moment I came here, one of the coordinators asked me for my slides, for my presentation in writing. And I'm sorry to say that it's still in the making, eh? But I want to talk basically making reference to my experiences in the field. And I want to share a story or two to provide some illustration on what I'm talking about. I want to refer to leadership and governance interventions in as far as multi-sectoral approaches are concerned. And I can see in the program it says expert talk. Am I an expert in this? I'm not very sure, but maybe from the experience, I'll be considered an expert. So we want to make reference here together on matters to do with multi-sectoral synergies in the successful implementation and integration of, I want to talk about the three, of course, the triple threats, not only GBV services. Colleague, when we talk about multi-sectoral synergies, I'm sure we're talking about collaborative efforts. And I said here, the day yesterday, that when you talk of collaboration, you're talking about 3 C's: communication, cooperation, and coordination. Back in the 1990s, there was so much concerted efforts among all actors, and the government came out strongly on issues to do, especially with HIV and AIDS. There was also a very strong approach towards sensitization, to the extent that almost every part of Kenya was covered, from Nairobi to the smallest villages in the country. Over time, that has gone down, and what we see right now is about efforts to do with the health services, the medical, and many other partners, and a few government departments. We would have units in all ministries and all departments of government, HIV units. Even at the county, then there were districts, not counties, and sub-counties. Then I was the DO. And I remember in Wajir, my DC called me and told me to establish a unit within my division. Now, those structures are no longer that active. They may be there, but not very active. They're considered redundant. Same case applies to matters to do with teenage pregnancy. We used to do a lot of talks in barazas, in churches, and in many other forums. We used to talk a lot also about SGBV. But currently, what seems to have gained strength and momentum is more of SGBV than these other triple threats. I said here that in the last 2 years, our CS Matiangi called all of us, English Marina Uko Mombasa, and we had all the experts talking to us on the triple threats. And there was an established kind of structure referred to as Intergovernmental Consultative Framework for Gender Against Triple Threats. We have this even right now in the county, meeting at least quarterly. But seemingly, and based on the experience I've had in chairing these meetings together with the county government, The non-state actors have overwhelmingly taken over kind of from us. We rely on them so much on the funding, and to the extent that we take the debt that they give us, we adjust kind of to their programs. Because anayekupea pesa ndio kila kitu, sio? Si kweli? Huko nyuma mnanisikia vizuri? Sasa kama huna pesa, wewe unakubali vile unaambiwa, si ndivyo? So they have kind of hijacked everything from us. So what are we saying? That apart from this structure that we have, we are meant to believe, based on training, I wouldn't want to say classroom instruction, but from the same activity that we've had, each and every structured government has a role to play when it comes to the triple threats. When I look at this room right now, it's full of medics. More of a medical approach. I know you've had lectures on the multi-dimensional, approach to the triple threat, but each and every sector seems to be more concerned about its activities. And nobody can deny here that majority of you are from the medical field. I'm not from that field, but I think I have a very big role to play as a coordinator of activities, national government activities in this county. So what are we supposed to do? Do we go the way we are going right now, allowing non-state actors to be dominant in our activities, in our talks? Or will we claim our position as it should have been? This structure I am referring to has its membership as follows: county commissioner or county secretary, whatever, alternative kind of chairmanship. Then CEC, gender, health, member gender, health, police, judiciary, ODPP, gender, children department, education, NCPWD, social services, youth, non-state actors. But I can tell you that we still have challenges with this approach. As I mentioned, the first approach is about funding. And the second approach is like, even my members, when we call for these meetings, which are basically quarterly, many from state actors attend, and few from the national and county governments actually come. It's like we've taken it to be like a side assignment, not the main assignment for us. We don't give it the seriousness it deserves. Why do we have all these members? I said this is a multifaceted, multi-dimensional kind of work. It's not only a medical kind of work. Yes, we know, we talk of HIV, for example, and even these others, there are always roles for the medical practitioners, and we appreciate their contribution. Basically, they do a lot of work. But when you talk about children's officer knows the kind of role that he or she is supposed to play. He has an instrument, he or she has an instrument, a statute, a legal statute to implement. Education department, same thing. Youth, social services, same. Gender, the police as well. The police will be basically concerned with investigations, arrest, and prosecution, together with the ODPP. But what are we talking about? Much of this is about reactive kind of. We don't talk much about prevention. The preventive approach of the 1990s, as I say, has gone down, not very strong. We are no longer proactive as such. We are reactive. For example, the police are more concerned with the ways of acting that I've mentioned. We used to have lots of stock in the education department. I wonder if the education department is here. Is it represented? Education department? Is there anybody from education? Okay. So there seem to be lots of gaps that we need to address. And sometimes even the excuse given from other members not attending these programs is that they have competing activities. You know, everybody seems to give the impression that he or she is very busy and cannot allocate the little time that we're asking for. How else are we addressing these issues apart from the structure that we have? We in the Ngao fraternity are busy propagating this gospel in all our barazas, from the county level to the smallest units. We are under instruction in writing to be talking about the triple threats in each and every baraza that we hold. And we always impress upon the churches to do the same in their activities on Sundays or any other time Saturdays, for those that go to church on Saturdays, and even during the youth, meetings. But somehow, if the churches and the mosques have let us down, I happened to talk to a friend who is a reverend. Nawambia bwana muongee hii maneno ya wasichana na wavulana, free mingling and relationships that don't have meanings, that are just lustful, Wasichana wanazaza, bwana muongeleshi. Akasema bwana county commission, the moment you start that talk in church, utajikuta kwa peke yako kwa kanisa. All the youth watatoroka. Hawatakuwa hapo, hakutakuwa na sadaka. Unanielewa? So this kind of fear, they will talk, churches will talk about, the boss will talk about many other things, but kind of evade that kind of a talk. So what about the mentorship programs? Because we are supposed to be mentors, we're supposed to be giving some guidance and counseling. What about the parents at home? Recently, we've had an upsurge kind of cases of defilements. Tena ndogo dogo, underage kabisa. Some as young as 3 years old. Can you believe that? Almost every month, our security records show, but Friday we'll have a security meeting, and there'll be more cases to discuss in that meeting. Our records show that there are some defilement cases, 4 to 5 every month. And we also get reports about girls. That's very common. So the police are very busy in their investigations. What happened to us as parents? In Konoin, for example, we've had cases of girls, very young girls, being raped. Kwa hiyo mishiki ya majani hiyo. That is where tea is grown.